Good morning. I trust you all had a good evening last night. Thank you so much for getting up early again for our session today. This morning we're going to talk about behaviours. Now, one of the things that one of the speakers pointed out to me this morning when I came in here was how behaviours have consequences. And I was just going to look at a tweet that I saw from yesterday because the ATAC guys asked me to read something out, but as I was looking for that tweet, I found Professor Carney's tweet from 10 hours ago, and it was a genuine question to the group here, if you could please let him know. Is it possible to die from cheese poisoning? Asking for a friend. Yes. But I think the fondue night was fantastic, and I had lots of great conversations yesterday. But the genuine thing the ATAC guys want to make clear, is that their courses for booking are opening up for 2025 shortly, so please have a look at their website if you're inspired to book for one of their courses. So, this morning, talking about behaviours, in our practice, we look after people, we look after ourselves, and we interact with a huge range of people at the worst days of their lives. And we don't really get trained very much in how we behave and what we do. Our first speaker is a returning speaker, Ross Fisher. He's a paediatric surgeon in Sheffield, but he's internationally known as a man to teach us about human factors, about presentations and skills, and he's going to start off by talking about looking in the mirror. Good morning. How we make decisions is important for the outcome of our patients. How we think about how we make decisions is actually possibly more important. And that's what I'm here to talk about this morning. We need to think different about how we think. Now, a strange thing for a speaker to do is I'd like you all to get your mobile phone out and take a selfie. And I'm serious, get your phone out and take a selfie. I know some of you are very good at this. Some of you have now just taken a photograph of your foot. Some of you are checking your WhatsApp messages on Facebook and all that stuff, but take a selfie. And what I want you to do is look absolutely serious about this. I'm not going to speak for 1 minute. I want you just to look at yourself.
I use silence quite a lot in presentations, and people say that's the bit that they learn most about when they just have to think rather than people talking to them. So I'm a pediatric oncology surgeon, and a few years ago I had to do a biopsy on this. Now, I think most of you will recognize there's a fairly significant problem here. So this is a child with a pelvic tumor. It turned out to be a neuroblastoma, but I had to do an open biopsy on this to get appropriate tissue sample. Fairly straightforward approach, made an incision, and then there was, I think we call it audible bleeding. It's not just bleeding, it's not just significant, it was audible. So first thing to do in bleeding, you don't need any fancy medicine. You have one finger and you put it in the hole. And the bleeding slowed down, stopped with direct pressure. The next most important thing that I can teach you about bleeding is do no more. Just stop. Keep your finger in the hole. Stop for 3 minutes. Then I took the swab off. More bleeding. So I put direct pressure on that. I announced to the anesthetist that there was significant bleeding. We agreed that we would activate the major hemorrhage protocol. We got tranexamic acid. We called for another colleague. We got the vascular clamps that we would possibly need. We got different suction, and we maintained pressure for another 5 minutes. At the end of that, there was slightly less bleeding, but we're still in a fairly significant position. So what we did was reposition the packs around the tumor. We identified a lateral vessel, got control of that, tried some sutures, and eventually we had control of the bleeding. Carried on, did a biopsy. 3 days later, my registrar gave me his portfolio reflection on how amazed he was at the practice of bleeding control, about the stepwise approach, about maintaining calm, about situational awareness, about how we had gained control of a very dangerous situation. I did not recognize that. I didn't realize what was going on. I didn't see anything written down there about how I'd made a huge mistake in cutting into the wrong place. He had not recognized how terrified I was, that I believed that this was the end of this child's life, and that if someone else had been there, they would not have made that mistake. He reflected on what he saw. What I felt is what's called the imposter phenomenon. I firmly believed that someone else would not have made that decision, that they would have been in better control, that they would have done it quicker and without a problem. They may not even have made that mistake in the first place. And what's important to recognize is that 70% of us, whether we identify as male or female, have a constant issue of the imposter phenomenon. That's 70% of you. The way we think about how we make decisions has significant implications for the decisions that we make. So the imposter phenomenon is well recorded in the literature. It's researched, and there's a lot of evidence about the very different types that there are. There are 5 major types. The first is the perfectionist. You have to be correct 100% of the time because, well, firstly, that's what patients deserve. But if you're not, then that's when you will be found out as being the imposter. The second type is the soloist. They do everything themselves because they cannot trust anyone else to do something, because if they did, then bad things would happen. The third is the natural. They haven't understood how they've got to this position of excellence because it didn't seem that hard. But their biggest fear is that that luck will run out very soon, and that's when they'll be found to be the imposter. Then there's the superhero who firmly believes that they can do everything and attempts to do everything because that's the only way to go. Or there's the expert who gains qualifications and further degrees and further positions and more work because that protects them from being found out as an imposter. Now, there are problems for all of these. The problem for the perfectionist is that perfection is unachievable. And in that will come failure, and that's their horror. Those who believe that they are soloists don't realize that actually working in teams who are much, much more effective. The natural, they just don't know when the problem's going to come because you realize that error is ubiquitous. It happens to all of us. It doesn't indicate that there's a problem with you. And the superhumans, let's face it, unless you come from the planet Kryptonite or you've been bitten by a radioactive spider, you are not superhuman. You are about to burn. All of these are a problem of the way that we think, and this is called metacognition, how we think about how we think. Now, for some of you, you've managed to reject all of that because either you think it doesn't describe you perfectly, or in fact, it does describe you perfectly because you believe you are not an imposter phenomenon. You're actually an imposter, and you're just going to be found out because it's not a phenomenon, it's a fact. The way we think about how we think affects the decisions that we make and therefore affects all of our patients. True imposters don't believe that they're imposters. So, then what we actually have to do is consider how good we actually are when we take the mask off and look at ourselves. And for that, we have this ability to question just how good we really are. And there has been a lot of psychological research done on this. And in particular, a seminal paper in 1999 asked, uh, asked the students that they were testing how good they thought they were at numerous tasks. And then they were tested on these tasks to find out how that reflected their actual ability. The paper is published by Dunning and Kruger and has become world famous for identifying the fact that we are very poor at recognizing how good we actually are and how we think about what we do. That inability to accurately diagnose our abilities is another failure of metacognition. Now, this has impact because people who are not aware of how unskilled they are will make decisions on the basis of how skilled they think they are. And that is clear about whatever you're doing, whether it's thinking, deciding, operating, or anything else that we do in life. And the Dunning-Kruger principle has been expanded through all of research to look at not just simple tasks, but complex tasks and multiple disciplines and practices, whether that's outside of medicine or inside of that. There is a problem with how we think about how good our abilities are. Now, the Dunning-Kruger graph is world famous to many people, and most of you will recognize this. Some of you may be aware that there are issues with the Dunning-Kruger research that have been shown that it's probably just a regression towards the mean. Some of you will know more than that. There's a mathematical study that shows it's probably just down to chance. And some of you may even be aware of the Swedish Air Force using the Dunning-Kruger test to assess new recruits about their abilities. But what's really interesting is that all of those facts merely show that you are ignorant about Dunning-Kruger. Because this is not the Dunning-Kruger graph. This merely comes from a comic book and has now become world famous as the Dunning-Kruger graph. People even give lectures about Mount Stupid and the Valley of Doom. This is about ignorance. The evidence that the mathematical model shows that there's a problem has now been refuted by further research. And similarly, the regression towards the mean has been shown in more complex issues that the Dunning-Kruger approach is entirely reasonable and describes metacognition failure. And lastly, there is no such thing as the Dunning-Kruger test for the Swedish Air Force. Now, what is interesting is that many people are now in your head saying you still don't believe me about Dunning-Kruger. And what I would ask you is, have you actually read the research paper? Have you read the subsequent book chapters and further research that shows that in fact you are Dunning-Kruger about Dunning-Kruger? Because this is the example. This is not the graph. This is the graph. It bears no relationship to it. And often this is the problem, that people have a justification about their understanding of an issue that they will firmly cling to, believing that they are correct about what they are saying. You are Dunning-Kruger about Dunning-Kruger. Mostly because in your mind's eye, you know people who are unskilled and unaware, and that you don't want them working in your department. But what that is evidence of is not that Donald Trump is Dunning-Kruger, or that people who don't believe in vaccines or COVID are such. But actually, Dunning-Kruger is not about assessing other people, it's about assessing me. And this is the point that they were making with this very simple graph, is that you do not know where you are on that graph. You do not know what your abilities are, your decision-making skills are relative to other people, because we're not tested on these things. And our belief systems behind that affect how we will then behave, even in the way that you are still trying to justify your knowledge of Dunning-Kruger. So here's the thing. Our metacognition is affected by what we think of ourselves, by what we think about our own abilities, and by our biases. Now, a bias is a way that affects the way that we think. What we'd all like to believe is that we all think very well. We make good, rational, scientific decisions based on the evidence. But I think, as we're all clear from Sarah Krager's amazing talks, is that sometimes our knowledge runs up against someone else's knowledge, and we have a problem with that. We have a problem not because of the science, but something else. And that something else is a bias, a cognitive bias. What that is very difficult to come to an answer to. These are just a few of the cognitive biases, and I'm going to go through them individually over the next 37 hours. The point is that there are many, 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 many influences on the way that we think, not on what we think, but the way that we think. And that's essential for us making important decisions on a regular basis about the patients that we care for. One of the most important is called the anchoring bias. Now, the anchoring bias means that you will hold firmly to your first opinion on something, and changing you from that is very, very difficult. It affects your thinking about subsequent decision making, such that if a patient is brought in who is described as being hypotensive, your further decision making will be influenced by that, even if the first blood pressure you receive is normal. Now, of course, we refer back to Sarah's talk. The blood pressure is not everything, it's about perfusion, but hold that idea, because that is a bias that affects your thinking. If you'd been told the patient was normotensive, you would have thought differently. The next bias is what's called confirmation bias. We seek evidence that supports our view of what we believe to be correct, and we refute, even without evidence, evidence that is contradictory. Think of that thing that you do that someone is challenging with research. It might be direct laryngoscopy, it might be Reboa, it might be your management of hypoperfusion. We seek confirmation of our own biases to confirm that they are correct and exclude evidence that may show it to be different. Now, of course, you wouldn't do that, would you? Not you, because you have a good view on the world. You can see bias in the way that other people behave, and that's perfectly obvious. The bias in the way that the surgeon brings in the patient, and you think, him again, he's always having complications. This is just another of his complications. We see bias in other people, but what we don't do, because we believe we are unbiased, is realize that we have what's called a blind spot bias. We all have a blind spot. It's at approximately 4 o'clock in your right eye, 8 o'clock in your left eye. It's where the optic nerve comes in. And believing you don't have a bias is a failure. It's the blind spot bias. We all have biases. They affect the way that we think, and we need to recognize that this, therefore, affects our patients. Go back to your selfie, please. Take it out and have a look at it. What I want you to do is really look at that person. Think about the complexity of that person. Think about all the things that you've gone through, positive and negative, the way that you've lived your life, the person that you've become. Many of us look at that with a negativity. We shouldn't. We are amazing people. You do incredible things. We need to realize that the person you see in the mirror is not that person, that there is complexity in you, that there are ways that you think and behave that affect your thinking. But the truth is, what you see in your selfie is a mirror image. It's not the real you. And the same applies for when you look at someone else. They are not simply the person you see. They are a massive, amazing collection of thoughts and experiences that affect the way that we think. And what we need to do is, as Sarah said, think better. Don't be worried about your problems, about the way that you think about your metacognition. Realize that a bias is actually better described as a cognitive disposition. It's a way that we think rather than a negative thing. The way that we think is wonderful because of the amazing things that we do. So what I want you to do is change the way that you think, not to anything different, but just think different. Instead of hypotension, think about hypoperfusion. Instead of about the blood pressure, think about improving the perfusion. Instead of just thinking, think different. You're amazing and keep on making those decisions, but just be aware of the things that might influence that and think different.
Amazing and thought provoking as always, Ross. Any questions?
What do you think that management has to do in contributing to imposter syndrome when they pathologize mistakes instead of recognizing that it's part of the human condition?
Uh, I have about 3 talks that I can give to that, all of which are deep personal experiences. I think it's absolutely appalling that we don't recognize the person within the problem, that being the physicians, and the impact of that on the physicians. That we need to recognize that context is important as well as the person and support them through that. So that what we deal with effectives in these complaints or issues is simply the facts and not the metacognition. And the why did you do this is actually more important than the what did you do. So yeah, it's essential. I don't think many of us actually address that either, let alone management. It's something that we need to address, the way we think about how we think.
I was going to ask you, do you think we should be taught about this sort of stuff at school, medical school, postgraduate? What level should we start actually reflecting on how we make our decisions?
Probably all the way through our lives. It's taken me till 60 to start to think about this sort of stuff. Um, all the way, we should help people understand that. That's where good and effective debriefing comes from, is an understanding of the rationale behind an action rather than just the action. It's easy to say you shouldn't have defibrillated that patient, but understanding why then speak to the metacognition of the thought process that goes on with it. And if we start to understand that, that's where high functioning teams come from. So from the very beginning and all the way through.
Amazing. Thank you very much. Anyone else from the audience? Or?
Do you have an idea how to apply this in your daily life to suspect yourself? Because many of the bosses don't help you to find out where on the curve you are really. So do you have a practice you do on your own?
Um, I think it's very personal. And I think once one recognizes that this is an issue, then one can start to help other people. So I'm working on this guy at the moment rather than on my trainees, but thinking all the time that there are these issues that they don't know how good they are. So help people to understand that, but then also help people to understand that fear of making the wrong decision and therefore doing multiple investigations comes not from just that that's the right thing to do, but possibly your thinking process around why it should be done if you're a perfectionist or if you're a belief that it's about more qualifications. So it sounds complex, and I'm sure it is really complex. It's just starting to understand that there's more than just our person and our decision. There's a lot of complexity to that. And that's where conversation and effective feedback comes in that we build as teams rather than just go, that was shit, don't do it again. That's how I was brought up, and I don't think that's the best way to be.
Okay, thanks.
Cool. Thank you very much, Ross. That was amazing again. Thank you so much for coming back.
Good. Yeah, going to be amazing. Yeah.
So our next speaker is Joy. She's an emergency and intensive care physician from Germany and from the north of Germany, a place called Strassund. Now, the next talk will touch on some areas that may make you feel uncomfortable, may make you feel or sort of think about things that are difficult. If you do, that's fine. And if they don't, that's also fine. If you have any issues, please talk to each other or one of us from the conference team, and we can signpost you. But the only thing I'd say is don't talk to Joy about it.
Hi. My first question is, what do you know about your last patient's caregiver you took care of in the hospital? Have you ever talked with them, except about the patient, how they are doing? Most of the time, when I'm also a physician, I was a wife, I was a caregiver, and I lost my husband 5 years ago. Until I was a caregiver, I was never busy. I was just, okay, we need the caregiver. We make the phone call, we need the medication list, we know, all right, there is someone who takes a patient to the hospital, and we really don't know anything about them. My journey from wife to widow started 2014. My husband gets a diagnosis of multisystem atrophy. I didn't know anything about this disease, so I look it up. It's a very rare neurologic disease, like 4 of 100,000 people. There's no cure. Thanks. And you're just sitting around and looking over the years about how somebody can't move, can't swallow, and cognitive, they're totally okay, but they can't talk at some point. After diagnosis, they die 3 to 5 years and aspiration pneumonia. So my husband was a Dutch guy. I took care of him 2 years at home next to my residency as an orthotrauma surgeon. And at that point, my journey as a caregiver started. I saw a lot of caregivers in the emergency department. They were sometimes aggressive to get the family member admitted to the hospital. There were nurses there talking about, they want to go to a holiday and they want to get rid of the patient. Some young doctors still think about it. But have you ever talked to the caregiver? No. Have you ever talked to them and asked them when they slept more than 8 hours or more than 2 hours sometimes? I had situations, I came home from the night shift and I was up for 48 hours because I have enough to do. I have the side symptoms of his medication. He took it 6 times a day. At the mobile nurse 7 days a week at home, in the morning, in the evening. So there's no privacy at home. And I was just end of my 30. So none of the doctors was asking me, how you doing? At end of 2015, I happily get a nursing home. I was physical really at my end. I had just like physical symptoms like chest pain, like I thought I have a heart attack. I went to the hospital and my colleague was asking me, what if the troponin is positive? What are you doing? My answer was, I'm going home because there's someone who can't take care of him. And most of the time when you think back from your patient and the caregivers, or the caregivers is your patient, most of the time they say, I can't stay at the hospital. I have to go home, and understand the situation after I was in that situation. So my husband get admitted to the nursing home in Germany. It was physical, was sitting in the wheelchair. The meal was, how do you call it? Making it puree. So his swallow problem, he can't take water without picking up. So everything changed. He was some person, he cooked, he loved to travel, he made a lot of sports. He can't do anything of that. So we starting talking about euthanasia. Where stops the quality of life? None of his doctors talked about him, about the situation. Everybody was like, his wife is a doctor. She will manage it. But I was looking at me like, I'm the caregiver. Most of the situations, the doctors don't explain me, you're a doctor, you know that. Some situation, I'm an also trauma surgeon. I have to read it. So afterward, I have the fellowship for intensivists. So some situations I know, but euthanasia was a really important subject, which I have to keep talking about him because I knew my husband. He wouldn't choose euthanasia because of me. So I want to give him the opportunity to take his own decision. And he took it. End of January 2000. About prepare the funeral of your child, of your loved one. Can you do it? No, nobody can do that. We are protecting our emotions. But what do we be prepared? Die in the next couple of weeks. Important part of the whole journey from your patient, family member, are not prepared because they work, they have their own other decisions. Talk to them first and not just, I'm sending home. It's Friday and I have to send them home. And I had the situation in my own hospital. The urologist just saying like, I have to send your husband home. I was on call that night. I was just like, we can do it. Just tell my boss, head of the department, that I'm not doing the call. I'm going home with my husband because there's nobody at home to take care of him, even the mobile nurse. So that was a really short message, I think. Thank you.
Thank you, Joy, for sharing that with us. I don't think it would be appropriate to take questions after this, so we'll move on to the next speaker in a moment. I think Jim asked if we could take a 5-minute break before the next talk. So if you'd like to just go grab a coffee, just take a moment, and then we will restart.